Shall we start?
Yeah, please.
Okay. I don't think we have the Kim stream from Trivandrum, so we'll move on to the rainbow cases. Okay. Yeah, Anas, if you're there. Dr. Lokesh, I can't see any of the fellows on the panel. Yeah, any of the presenters there, if they can present the case.
You can start off this one. He's just joining. Yeah.
Yeah, because the rest of the cases are from rainbow. There's no other cases.
Hello, am I audible?
Yeah, Anas, go ahead.
Yeah.
Sorry, network issue. Yeah. So this is regarding a developed normal child. She was currently 9 years. She attained walking and bicycle by 1 year of age, and started nursery by 5 years of age. Went to UKG for 1 year. Birth history was uneventful. She is a third child born to non-consanguineous parents. Vaccination, she was partly vaccinated till 9 months. The family is from North India, currently in Hyderabad since the last decade. So story started from 5 years of age. She had sort of fever for which she was admitted. Fever with mild encephalopathy. She remained dull for 7 days, but she was able to recognize parents going to toilet independently. So that was one event. And after that, she is fine back to baseline. She did not have any seizure at that time. And we didn't have any previous records from that episode. At 6 years of age, parents noticed that the right great toe would intermittently go into some stiffness, and which was worsening with activity. So initially they noticed it was at the great toe, and then it spread to the foot, and later to the whole limb. And she was able to walk with slight limb, but it was okay. Over the next year, the dystonia of the right lower limb increased and spread to the right upper limb as well. She had difficulty in writing, and there was worsening in her handwriting as well over the time. Because of this, she stopped going to school, and then she also had functional difficulties in walking and getting up and down the stairs. But still, she was independent for most of her activities. She started to use left hand for writing. Then, in the past 6 months, mother noticed there's some deviation of the mouth when she is smiling, and this was persistent for the next 5 to 6 months. So since the past 3 months or so, they noticed that she's having right focal seizure. It was very brief, like in dystonic posturing. Initially once a month, then twice a month. In January, the frequency of these seizures increased to almost daily, multiple times a day, for which she was admitted the referral center. She remained there and was evaluated partly during this hospital stay. She almost stayed for a month over there. But as the seizure frequency started becoming very debilitating, she was referred here. The semiology was right focal dystonic with ictal retching, watery vomiting. Post the event, she had become back to baseline. She could not recall the event, but she would get a premonition before the event. So when she was brought to us, she was in post sensorium, partly because of the seizure and partly because of the loading doses she was receiving, and she had increased work of breathing. She was admitted at her ER and kept on non-invasive ventilation. She was very drowsy. But over the time, we were able to titrate her anti-seizure medication. Her seizure frequency had decreased. Next.
That's all I.
Yeah. And so then we got an imaging done. This is
Okay,
the
so I,
prior
yeah.
prior to that. Yeah, when because of the weakness she was being evaluated. This is prior to the seizure episodes. The MRI.
Okay, so I have two sets of scans. One is from last year, one is more recently. This is from May 23rd, 2023, and I have T2 axis over here, and you can appreciate there is hemispheric loss, volume loss on the left side. See that the cortical volume is reduced, the basal ganglia volume is reduced. Yeah, so predominantly left cerebral hemiatrophy with deep brain nuclear atrophy and some corresponding increase in the size of the frontal horns. I cannot appreciate the structural abnormalities per se, at least on these sequences or these scans. Right side appears to be relatively normal in comparison to the left. These are diffusion sequences. Again, cannot appreciate any areas of restricted diffusion, though these are just, slightly pixelated images, but still nothing stands out over here other than the volume loss on the left side. Then this is the most recent scan, done I think a couple of weeks back. You can see here now you have more acute changes or early subacute changes on the right hemisphere. Here the cytoptic edematous changes predominantly involving the cortical regions of the perisylvian region out there, the frontal lobes, the parietal temporal lobes. Corresponding flare sequences demonstrate the edematous changes, also involving the subcortical white matter from regions of the deep white matter. And you can appreciate the chronic changes on the left side. Again, T2 demonstrates a similar picture. Posterior first, I mean, the infratemporal region are relatively less involved, maybe some degree of atrophy in the vermis out there, but predominant changes, the acute changes on the right hemisphere and chronic changes on the left hemisphere. SWA sequences that could appreciate some areas of blooming, possibly some areas of dystrophic mineralization out there in the left basal ganglia. No vascular abnormalities per se. The edema is masking the vasculature out here, but no prominent blooming on the SWA sequences on either side. So there is some vascular perfusion abnormalities. No ASL was done or no perfusion scans.
Yeah.
Yeah.
So when she was with us initially, we had titrated her seizure medication. We were able to decrease her seizure frequency, and we were also able to send her to ward. She was shifted to ward. Her sensorium improved, and she became. She had right hemiparesis. That was a baseline, but she was still able to. For a couple of days, she was able to walk. Again, her seizure frequency increased. But thing is, all the seizures which we had documented were on the right side, and when we had done EEG, it was only slowing. The initial scan. Yeah. So
Yeah, that's right.
so based on the initial scan, what we had from the referral center and the natural history what she was following, we were thinking in lines of Rasmussen or HHE, and we thought should be a good candidate for hemispherotomy. We wanted to evaluate her once her seizure frequency is better and wanted to get a proper epilepsy protocol MRI. But before we could do it, she again started to have flurry of seizures for which she got intubated, and then again she was having seizures on the right side, after which we got the scan done. So after the scan, our differentials were, I mean, now we realized we could not offer a surgery, at least now, until we evaluate it further, because so far she had not been evaluated formally at the referral center. They were just treating it like Rasmussen. But now, because she never had any seizures initially, at least till the scan was done on the left side, so this new MRI scan was quite a new revelation for us. So we're wondering about the work we had. After this, we did CSF. Wanted to, because she has partly vaccinated and history of measles was there in background. We wanted to, although she never had any myoclonus, we wanted to get measles SSP out of the way. We did send measles, it came negative. We sent autoimmune, although it was not following a classical autoimmune natural history. We sent it that as well, as it is treatable. That came out to be negative as well. CSF lactate or mitochondrial, even that had come negative. Now that is a question of what could be what are the other possible differential at this point of time.
Okay. So we're thinking channelopathies, ATP1A spectrum, CACNA1 mutations, mitochondrial as the differentials. So based on
we
both
have
the scans.
yeah, we have offered them genetics, but I think they're out of financials, so we'll see.
Okay. Yeah, I'll open the case.
In my impression, Rasmussen encephalitis is very unlikely. There is a controversy whether this can be bilateral, but this is a chronic condition and not an acute one. And here you have a kind of a two-stage or at least two-stage cause. You have now an acute problem on the right side, but you have pre-existing changes on the other side. So I would favor a genetic condition. I will not be able to pinpoint exactly which one, but this is likely genetic, metabolic, channelopathy.
Yeah, exactly, Prof. This is what I think we thought after the second scan. Initial part, we were thinking because there is only basal ganglia atrophy, we were thinking whether it could be Rasmussen, but the previous history of all this dystonic thing couldn't be explained by that. And now we have shifted to another place, and genetics has been sent now. Probably we'll have an answer in a month's time.
All right. Anyone who has any other further comments? Similar experiences?
I just have a general comment to make, Nihal.
Okay.
We always mention CACNA1A and ATP1A for similar cases. CACNA1A, has anyone seen outside the context of cerebellar atrophy? Because the ones I have seen, of which I think I've seen 3, they all tend to have a lot of cerebellar atrophy. And I wonder if we can help differentiate using imaging in any way or the other. You can see these pictures from the literature. They both have cerebellar atrophy. It's just that I'm thinking if the family has limited resources, how much can we subject them to, and can that be narrowed? It almost calls for a bit of work if people in this audience here want to put their cases of CACNA1A and ATP-A1A together, for instance, and compare the two phenotypes. I think there'll be differences even on imaging, but the work hasn't been done previously. Just one question about the history. How long did you have this atrophy business happening before the second insult happened?
Actually, we have the scans from the last scan was 2022. So her problem started when she was 6 years of age. So she was not imaged initially. So at least after 2 years into the illness, we had an MRI, and that showed similar changes. She had multiple
Okay.
MRIs, but all were showing the similar
So
changes.
not a very long history of left-sided atrophy.
Yes.
Okay.
Can
And
I-
at the onset, did you have any hardcore evidence of epilepsia partialis kind of explosive
No,
seizures, or what?
at the onset, she only had this dystonic hemiparesis initially
Okay.
at 6 years of age. And over the course, which it was a progressive dystonia, and then the EPC presentation was a new thing, relatively past 3 months or so. So initially hemiparetic dystonia, and 3 years back, and 3 months the right EPC.
It's
So
very
they were not.
interesting. When you go back to the susceptibility weighted sequences, you actually see progressive mineralization of those structures as well. Apart from the atrophy, you've got an iron homeostasis problem going on the left at least. You mentioned dystonia, so that came to mind. And I wonder if the similar process is beginning to happen on the other side as well. Yeah, we'll have to come back to this when we know exactly what it is. But if anybody's keen to put CACNA1A and ATP1A3 next to each other, we'll be very happy to help out.
Of course, Dr. Mankad is right about the cerebellar atrophy, but in the literature, there are a number of cases with unilateral acute swelling, sometimes near fatal. I have seen 2 confirmed cases. So CACNA can present with a mainly unilateral problem with a midline shift.
Definitely, in the beginning of time, that's what confuses people, isn't it, Eugen? Because they think about a unilateral problem only. And this kid also would have presented as a unilateral problem once upon a time.
And even the symptomatology, the other side was completely silent. I mean, even now, when we there's no weakness or anything that could. Only thing is EEG was like when we had done EEG, there was bilateral slowing, generalized slowing. So that was one odd feature. But yeah, it's
I had a
Just
question.
Just to kind of confirm one thing, you're not dealing with two pathologies here, you think, right? She doesn't have, you just mentioned that there's nothing coming apart from general slowing. It's not a transient viral encephalitis hitting the normal brain, right, in this case?
So we did CSF analysis and we have not seen the viral panel, but CSF analysis was normal and autoimmune panel was sent. We're thinking of, and as well as measles. We did consider the possibility of two hit, but we're not able to explain with that either. All the
Okay.
things.
Dr. Rajesh has a
I
question
had a
there.
question. Yeah, I had a question. I came a little late. Was the diffusion restrictive?
On the second scan, I mean, the follow-up scan, yes.
It looked like, you have a dystonic hemiparesis, then you have, which I heard later, and then you have 2 episodes of seizures. I mean, were there any headache, vomiting features in the middle?
Nothing. No headache or vomiting.
It looks very much like a mitochondria. What about his nutrition or his stature? Was it short or anything?
She's overweight. Maybe.
Child was well grown, Rajesh.
Okay. Thanks.
Okay. So you're thinking genetic as a likely possibility, and maybe you'll get back to your answer in a month's time.
Just a simple question. If you ask for exome sequencing with a question of channelopathy or epilepsy, I think it doesn't matter whether you specifically ask for one single variant. I think this is all included in the bioinformatics, if I'm not mistaken.
Dr. Lokesh?
Yes, Prof. Yeah, yes, Prof. All the information is included. You have specifically asked for these variants.
Okay. Aarti, if you're there, you can go on to your case.
Yes.
Yeah.
This is a case of a 3-year-old male child with normal birth and development, was admitted with high-grade history of high-grade fever and loose stools and vomiting with severe dehydration. And within 36, actually, child was admitted outside. Within 36 hours of admission, he was noticed to have excessive irritability and diminution of vision. And he was searching for objects and he became completely blind. Visual acuity was only minimal perception of light in both eyes. Fundoscopic examination was normal and rest of neurological examination was normal except for a mild ataxia when he was trying to walk. And the visual evoked potentials showed absent waveforms bilaterally. And outside, he had received 3 doses of pulse steroids and then referred to nil improvement. Pulse steroids were continued after coming here. Like we did the MRI and then we continued the pulse steroids and gave IVIG as well. MRI.
Okay, I'll show. Okay. Yeah. The T2 axial sequence on top. You can appreciate multifocal T2 hyperintensities in the periventricular white matter, centrum semiovate on either side. The slightly prominent lateral ventricles out there. So mild reduction in the cortical volume, especially in the parietal lobes. Again, you have hyperintense changes in the brainstem structures. You can appreciate over here in the midbrain, also going up to the central tegmental tracts. Possibly also in the medulla and dentates are slightly hyperintense. On the diffusion, the multifocal abnormalities, some of them demonstrate restricted diffusion. Post contrast, the hyperintensity does not demonstrate any enhancement. There's a mention of optic neuritis. This was the only cut I had, possibly there, but I cannot appreciate any significant enhancement. If you come lower down, you can see the parotid glands, especially the left parotid, demonstrates the inflammatory changes which are enlarged in comparison to the contralateral side. So some degree of parotitis out there with these multifocal abnormalities in the white matter, and possibly some degree of optic neuritis on either side. Yeah, Arti.
Yes,
Okay, yeah. So we got the spine too. Spine, I could not appreciate any lesions in the spinal cord. Also, no significant enhancement, especially on the caudicon and nodules.
Is the cervical cord a bit fat or swollen? Can't really tell much, or is it normal?
I don't have an axial, but I think it's a normal for.
Okay. Yeah. Doubtful.
Okay, let's see. All right, Adi. Based on that, I think, yeah.
The CSF analysis was actually done outside. It was reported to be normal. However, we don't have the values. Total count at admission, he was febrile. That time the total count was 12,800 with a volume of predominance. CRP 0.4, lactate 52.7, and ammonia 79.3. And we had done a serum mumps, IgM, which was positive later on. MOG and NMO were negative.
Okay, so paratite is also explained. I think most common is
MRI and child developed it clinically. It was very evident after day 2 of admission in our center.
so we're treating this as mumps-related CNS changes, or so I could find. I mean, the phenotype is varied. It can have white matter abnormalities, multifocal abnormalities. ANX also can have some degree of mumps. But I think paratite is a more specific finding than the MRI findings.
I think you're seeing post-infectious phenomena here
Yeah.
than primary infection. What's happening to the venous sinus there? Is that okay on the first picture? I wanted to ask you.
This is post-contrast sequences.
Oh, is it all? Oh,
Yeah,
okay.
yeah.
Okay, that's
All
fine then.
post-contrast.
Okay. Yeah. Okay.
So it's
There's a bit of mumps happening in London as well. I don't know whether it's making a resurgence. It's only 2 cases.
So this child had received MR vaccine as part of the government immunization schedule, and probably that is the reason child was not immune against this infection. There's quite a bit of outbreak happening in some areas of Kerala now due to mumps.
It's all over India. It's all over India, actually. We are having in Bangalore, in parts of Maharashtra, there are reports everywhere of significant number of mumps. Some of them are very mild and some of them are very severe with meningoencephalitis. So we have reported to the health secretary here.
Are these patients who have been immunized or not?
They have had the primary immunization. The 5th year immunization does not contain mumps.
No, even the primary immunization now doesn't contain mumps. Only MR. From MMR, they have just taken out the mumps part. So they're not receiving any mumps vaccine nowadays. And
There is a huge outbreak all over the India.
Yes, yes. And we had meningoencephalitis also cases where there in schools also there are epidemics going on.
Yeah,
So this
I
is
think
the
it has to be
recent change
reported on
that
the
has
large
been
scale.
done in the national immunization policy. And
Yeah.
in this child, what was said, the initial presentation was said that actually child came without the swelling, and after 2 or 3 days only the swelling appeared. And first the symptom was complete loss of vision, and fundus was normal, and it was appearing like a retrobulbar neuritis. We had one picture from outside also, and this one. Both were showing that the retrobulbar part is up to the canalicular area. There were mild enhancement, not enhancement, it was a thickening that was shown. And main presentation was with complete loss of vision, and there are actually few reports of retrobulbar neuritis along with mumps. Whether it is a para-infectious demyelination or not, we are not sure. But the child responded to immune therapy.
Sorry, but a group like this, which is representing most of India and the important centers, I put it in the chat, but you guys, there's nothing showing on news here. There are outbreaks that are being reported like intermittently, but I think it becomes our responsibility to alert people about it. And for us, a peer-reviewed publication as an urgent correspondence is required. I want to know, particularly from Nihaal, who's leading on this meeting, as to who might want to lead on putting. I can see 5 centers here saying we've all seen cases, and it's still not known as such.
Actually,
we
we have
made a
informed our state surveillance medical officer, but nobody has done anything.
No, but this needs to be published in a journal which at least can reach out urgently. And we're talking about journals like Lancet or Neurology, essentially, for general public awareness. If it's happening in pockets in India, I'm sure it's happening everywhere else.
True. Yeah, no, definitely. We have also made a representation to Health Secretary, but it has not gone beyond that. So this is almost 2 months back. So I think that's a good idea. We should try and collaborate all the. These are all only 95% of this one. Most of them are treated in outpatients and sent away.
Yes,
so yeah, so I think we should do that effort.
The way to do that would be to have a separate meeting of people who are keen on getting involved. It'll be important to look at how many outpatients have been seen in the last few weeks in your respective centers, even if you survey 4 or 5 centers. And then it'll be a question of reaching out to the journal ASAP. I can help with that, but someone has to take lead. Nihaal, are you keen? Do you have time?
Yeah, I think
Maybe
we
for,
can.
yeah,
Somebody
yeah,
can
we can
do
do it.
it.
Yeah, we can do
Yeah,
it. No.
we can do
Actually,
it.
yes, AOCN can do, isn't it? Can.
It's not necessarily this one, ma'am. It will take a long time.
Okay.
I
Yeah.
think a group of us suggested, Mankad suggested we can just have at least few centers who are
Few
most of the
centers.
representatives will be in the meeting. We can just collect this data and then try and get it out as soon as possible.
With your permission, Nihaal, I'm just putting a chat for everyone here. I'll put my own email for now if a group of people are keen to, and they have seen cases and want to put this out as soon as possible. Is that okay?
Yes, please go ahead.
Because I know your conference is about to start in 5-6 days, but I'll help you out with that.
Just a minor point. I'm not, I have no doubts about your diagnosis, but as a virtual reviewer, I would ask, have you serologic confirmation? Is that really mumps? Could it be
Yes.
some mimics?
Serum
Just to make
IgM.
sure.
This IgM we have done, and that has come as positive. The child had initially started as left side parotitis, and then it spread to both sides, and the submandibular glands also got involved. And the presentation was exactly like the mumps. And mumps IgM antibody is also positive.
Thank you.
Eugen's point is very valid. Whoever wants to contribute any cases will have to show the workup of them, at least as basic as possibly done. But I think what we are seeing here is the para-infectious phenomena of these viruses rather than primary. It's hard to say.
Yes.
Hard to say, but a lot of the distribution seems like that. And I think the spinal cord, it's up to you, Nihaal, because you're steering the thing. It can affect the spinal cord as well, but it's a hard call.
Yeah. The corresponding axle would have been have to be pointed out. Okay. Thank you for the case, Dr. Kalpa and Aarti, and we'll try and collate the cases as soon as possible.
Yes, sir.
All right. Case 3, Harika, Dr. Nikit, you're there.
This is 13 months old female child born out of non-consanguineous marriage with history of foreign body impacted in esophagus with post-status endoscopic removal and post-extubation, hemodynamically stable and achieved a baseline sensorium. And on day 3 of admission, child had 1 episode of fever associated with refractory status epilepticus, for which child was referred to RCH in view of persistent seizures and deteriorating sensorium.
document क्या करना था लेके आऊं आपने
Yeah, go ahead, sorry.
Yeah, in view of persistent seizures and deteriorating sensorium, child was intubated, and child had persistent seizures requiring midas infusion and started on like requiring multiple AEDs. Thinking of like infectious causes, CSF analysis was done, it was normal, and HSV PCR was sent, which is negative, and culture sensitivity is also normal. And because of a fever trigger, thinking of metabolic causes like serum ammonia was also sent, normal, and lactate is also normal. And in your persistent refractory status epilepticus and encephalopathy, MRI was done.
Okay, I think it's an outside MRI, and you can appreciate bilateral diffuse extracortical brain injury, predominantly involving the peripheral regions of the brain, bilateral hemispheres, the subcortical cortical regions, with corresponding changes on the ADC sequences. I think we are just obscured by an artifact out there, but it was bilateral, almost diffuse process involving the bilateral subcortical cortical regions. The T2 corresponding changes had some additional abnormalities, some swelling of the basal ganglia, which did not show diffusion changes. But again, you can appreciate the subcortical cortical edematous changes out there on the bilateral hemispheres. No significant intracranial herniations at this point of time. Yeah, so this was a diffuse extracortical brain injury. And then 2 weeks later, do you anything in between, Harika? Sorry.
Yes, sir. Actually, child required mechanical ventilation for almost 6 days. Child was extubated on day 6 of admission, but the encephalopathy was persistent. Spontaneous eye opening was present, but no recognition, and flexor response to pain was present. But on and off, like brief seizures requiring multiple AEDs was required, and also child was given IV methylprednisolone and also steroids. Thinking of para-infectious causes, and but still the sensorium has not yet been improved. And also thinking of like cytokine storm may be there, like IV 1 dose of tocilizumab was also given. Now, like child was extubated and shifted to nasal form. Now child was shifted to ward, but brief seizures were persistent on and off. And in view of the persistent encephalopathy, repeated MRI was done.
All right. Repeat MRI again. The peripheral regions are demonstrating edematous changes, but we have some progression in the abnormalities in the basal ganglia, as you can see on the T280 sequences out there. Now, the deep and deep white matter also has some degree of possibly leukoencephalopathy related changes. You can see in the parietal lobes, the temporal lobes out there in comparison to the first scan. So some progression in terms of the central changes and the deep white matter. Yeah, and again, I think ALARD was just kept as the initial possibility on the first scan. Fires, I think, was mentioned as a clinical possibility. But now we're thinking more of genetic abnormality related seizure-related changes for the 2 scans. So I'll open the case if anyone has any alternate suggestions. We didn't do a spectroscopy. So no other sequences were done.
And in the CSF, did you find any neopterins and all those things going on?
I don't think we checked for neopterins specifically.
Yeah, the reason I ask
don't have.
is, how deep we go into the neuroinflammatory spectrum here.
Yeah, I think we don't have that standard facilities, but
Yeah, just go back to the history. I was trying to figure out.
So there was some degree of hypoxia, I think, foreign body post-extubation.
Yes,
if I'm
sir.
not mistaken. Then followed by fever related.
One day, like after extubation, child was shifted to ward, and child achieved baseline sensorium. And the following day, child had 1 episode of fever triggered status epilepticus with persistent encephalopathy.
Okay.
I had a question for the radiologist. I don't know last time you heard me, but when you have status-related changes, usually you get changes in the hippocampus and posterior thalamus. Am I right? But that was
Quite commonly.
Yeah. Otherwise, it becomes very difficult to know what is cause and what is effect, because generally, if you see any sort of acute encephalopathy often has status epilepticus, and it's difficult to differentiate cause and effect. So I was wondering whether, I read somewhere that the hippocampus should always, obviously, the most sensitive part to epilepsy, to seizures. And in the circuit, that's where the thalamus, the posterior thalamus pulvinar or whatever, also gets changes. So if those are not there, would it be still considered post-ictal or ictal changes?
Post-ictal will be tricky to call it, but here the hippocampus was hit, isn't it, from what you showed? And the other thing is that the cerebellum also is involved here. It looks more like more of a generalized neuroinflammatory process affecting the whole brain.
Romit has asked about anesthesia, which anesthesia has been given. Not sure. It was done in another hospital.
But what the team told us that child regained baseline sensorium after the after the child was out of, but child required ventilation for 2 days. That was odd because it was a very acute pathology. Child required ventilation for 2 days, but after the ventilation, baby attained baseline sensorium from what the mother was saying and what the referral doctor was saying. But we are not sure what anesthesia was given. We can maybe get that information from them.
Anything specific, Romit? Toxic?
Now we're almost 18, 19 days into the admission, and the baby is still sensorium wise improving, but very gradually. She's only started to open eyes and not even fixing properly, but able to recognize mother's voice. So that was the concern. The
And
long
still seizing as well. It's not behaving like a single point insult with recovery.
He says just wondering what was the initial insult. Immune-mediated encephalitis, AESD. I think that was thought of as the after the first scan. That's from Udava.
But we should not forget the context. I mean, this started 2-3 days following an intervention. This is not an concomitant or associated immunoencephalitis. Very unlikely.
What's the next
No,
step,
there was
Dr.
the
Lokesh? Yeah, something. Yeah, sorry, Dr. Lokesh.
No, I was saying that possibly there was some sort of hypoxic event during the surgery, and you get secondary brain injury a couple of days later. Secondary brain injuries.
Only thing odd was the restricted diffusion, which is persistent even on day 15, 16. And the flurry of seizures kept on coming, actually started increasing post-extubation. And every day there are multiple seizures which are persistent, which usually we don't expect in hypoxic. A single point, you have flurry and then you start settling down. So that was not happening. That was slightly unusual. That's why we did the repeat scan, which showed the persistent restricted.
The question of could it be press? Unlikely, I think. Yeah. Yeah, Dr. Rani, sorry. Yeah, please go ahead. Dr. Lokesh, what's the plan? Next plan? Do we send for any further testing or wait and watch?
Yeah, we have.
Yeah, go ahead.
Yeah, we have offered them genetics, but I'm not sure if that's gonna give us the answer. But we have offered them, and they're thinking about it. I think because they're sort of exhausted as well. It's been almost 3 weeks. They stayed for 5 days, and here almost 18 days. That's the plan, is to try to send the child home and then follow them up.
Okay, Dr. Abhi Patan asks, are the seizures myoclonic?
Yeah, multifocal clonic. Yeah, multifocal clonic.
Yeah. Initially it was on the right side, and now it's all multifocal.
Question is, can it be seizure-related changes? Yes, but we need to find out what is causing the seizures. Gap between extubation and fever with seizers.
So initial extubation. So I think there was 1 day gap. Next day after the extubation, she had fever at the referral center.
Okay, I think we need to again wait. Yeah, Tami mentioned this could be due to seizures, but possible, but we need to know what is causing the seizures. The etiology for the seizures, I think. All right, Anas, if you have any diagnosis, just let us know.
Yes. Thank you.
Okay. Okay, over to you.
Yeah. So this is a 4-year boy. They presented with swelling over the right eyelid since 1 month, for which they had come to us. But this similar history of left eye proptosis, for which they had come initially, were advised treatment, but they never followed up. On retrospective
That was
exam,
at 1 year, 3 months of age. The age is important.
Yes.
Now he is 4.5,
Yes.
4 years, no?
Yeah, yes, sir. So this was almost 3 years back, and they had taken some treatment for which this eye proptosis settled down. So now when they came back on examination, there was convergence, some proptosis on the right side. So we got an MRI done.
I have only one MR. Is that right, Anas? Yes.
Yeah, only one MR. Yeah,
Yeah,
done
okay,
at CT.
okay.
Yeah.
Okay, no, Dr. Loki, there were two MRIs, so I have the more recent one.
Sorry, one MR was done at CT Neuro.
Yeah, I got it.
Before
One
the
was done
intervention.
before, yeah.
Yeah.
So this is the latest MRI, and you can see that I have diffusion and ADC sequences, and you can see there's abnormality in the skull base on the right side. There is extracorneal abnormality out there with restricted diffusion on the right hand, extracorneal abnormality, and also you can see that there is going down into the skull base region predominantly on the right side with diffusion changes. There is some area of restricted diffusion, especially in the extracorneal abnormality out there. And FATSAT T2 sequences again can demonstrate heterogeneous hyperintense changes involving the right extracorneal abnormality, the rectus muscles, and also the catering of sphenoid out there, going down inferiorly and centrally also involved the body of sphenoid. And if you see on the coronal sequences, there is infiltration into the cavernous sinus, especially on the right side. T1, it is predominantly isointense in signals. And again, coronal sequences, you can appreciate the extent of the lesion going from the subcutaneous region up to the orbital spaces out there. This was a post biopsy scan. I think PET results were. Anas, if you can just highlight the main findings.
Yeah, so based on the initial scan, we thought it could be a pathology that is recurring, and probably maybe they must have taken steroids for which the initial lesion must have resolved, like a Langerhans cell histiocytosis. So based on that, we got a PET scan, which showed mild FDG avidity and ill-defined enhancing soft tissue attenuation around the extracorneal compound of the inferior lateral aspect of the right orbit, which can be seen in the MRI, and inferior orbital fissures. And then after this, we had done a biopsy of the bone, which showed some histiocytes. The initial impression by the pathologist is it could be Langerhans cell histiocytosis, but they could not clearly label it as such. An X-ray skull which we got, there was a lytic lesion of the high parietal region. So currently, the child is receiving treatment for Langerhans cell histiocytosis.
Okay, so we're working a diagnosis of LCH. I'll open the case if anyone has any alternate possibilities, given that the pathology is not 100%.
Yeah, pathology, they could not find the classical granulomas, but there is a lot of infiltration of histiocytes. And when I spoke to the pathologist at Nimans, they said it's a very likely possibility, but given the tissue was from the bone and whatever they could decalcify and see, they could get only that amount of information. They couldn't put it on writing, but they said it is very likely LCH.
I think that maybe in this case was the interval almost 3 years later into the illness, child had on the opposite side, and that was something interesting.
I think initially we thought of inflammatory. Is that right, Anas?
Yes, inflammatory
Yeah,
or something
yeah.
infective.
Yeah. Okay, I think given the pathology of inflammatory, I think we don't have any alternate theories.
Rajesh, any experience of this?
I agree with you. It's probably LCH only. Can't think of anything else. Really.
Thank you.
Right.
Somebody's mentioned the possibility of IgG4. That's interesting, but I've really not seen a case. Has anybody?
I think this is a disease of bone. The bone is extensively involved.
Yes.
So that makes it IgG4 disease
Less
less
likely,
likely.
yeah.
It's more of
Yeah.
meningeal.
Yeah, more pachymeningeal IgG4. Okay, Harika, over to you.
Yes, sir. This is a 4-year-old female child with complaints of new onset of neuropsychiatric manifestations in the form of abnormal eye movements for 15 days and behavioral abnormalities in the form of apathy, sleep disturbances for 7 days, and with seizures, with focal seizures and decreased cognitive function for 7 days. On examination, child was dull, apathic, with slow response to commands. And on examination, there is proportionate short stature, with weight being like 3rd to 58th centile, and also pyramidal signs were present.
Okay.
Um,
I have one video if you want to just. Sorry.
This is the first complaint they present to us.
For the radiologist, could you maybe describe what's on the video, Harika?
Yes, there is repetitive eye blinking, more on the left, and that occurring in clusters. These episodes were almost 5 to 7 episodes per day. Like initially, there are 5 to 7 episodes, but gradually over the 15 days, they were reduced in frequency. Now almost like 0 to 1 episode per day. And at this time, like when child presented with repetitive eye blinking, child was dull, like very less response to commands, and there was no speech output. She was comprehending, but there is no verbal output.
Okay. So I think to think about once you see this, just as an approach, you want to. Okay, I have your clinical differentials.
Yes.
Yeah, this moments we thought of whether it was a more tics kind of thing, ocular tics, because she didn't have any.
Look at that.
Yeah. So that is one of the possibility we thought of, whether it was, but she had come with a MRI which was done, which had shown some findings which drew her attention to something else. I think that Harika will discuss.
Yes.
Yeah, because you have this pediatric acute neuropsychiatric disorder, they come with tics and they come with neuropsychiatric changes and stuff. And,
Yeah, go ahead, Harika.
In view of new onset neuropsychiatric symptoms in the form of seizures and altered consciousness, cognitive impairment, which was of subacute onset with
No,
no
this is
fever.
later on. No, she came back. She went out from OP.
Yes, sir. Yes, initially child presented with this repeated eye blinking in the form in clusters, and the child was brought with the MRI done outside, and it was to like pituitary enlargement.
Let's see the MRI.
Yes, sir.
Okay. So MRI on top, T2 non-contrast, bottom are the contrast sequences. You can appreciate there is enlargement of the pituitary gland and also the pituitary stalk of there. Post-contrast is diffuse homogeneous and predominantly homogeneous enhancement of the pituitary gland and the mid and distal aspects of the stalk. Coronal sequences, you can appreciate the outline of the gland out there. This is actual sequences and fast sequences again demonstrating homogeneous intense enhancement. Additional abnormalities on the flare sequences. You can appreciate these multifocal abnormalities in the deep white matter, the periventricular, posterior periventricular white matter, some degree of prominence of the lateral ventricles. No corresponding changes on the diffusion weighted sequences, and no corresponding changes on the stabilized sequences in terms of mineralization or hemorrhage or hemostatin deposits. Even the clinical history and the appearance of the pituitary gland, we thought of possibilities of hyperplasia or inflammatory changes such as hyperphysitis, and the age, and less likely possibility of a macular adenoma given the age of the child and also the imaging appearance. Then then we evaluated the child, and Harika, you can.
Yes. In view of this pituitary enlargement, endocrinology workup was done, in which TSH was more than 100 and with low T3 and T4, and serum prolactin was elevated, 180 nanogram per ml. And thinking like most common cause being like acquired one, being autoimmune cause, ESR was also done, 80 mm per first hour, and antithyroglobulin antibodies and anti-TPO antibodies were highly elevated. And ultrasonogram thyroid suggestive of increased ecotexture of thyroid gland, and ANA panel was sent in view of neuropsychiatric manifestations that can be due to autoimmune etiology, but it was negative, and serum NMO MOG and serum NMDA antibodies were sent. Today we got serum NMDA antibodies, which was very strongly positive.
Wow.
So with subacute onset of new neuropsychiatric manifestations and like child being dull with slow response to commands and no verbal output, and child also had proportionate short stature, and also history of constipation was there since 1 year of age. With this presentation, our diagnosis is autoimmune encephalitis, likely steroid responsive encephalopathy associated with autoimmune thyroiditis.
Now with NMDA receptor encephalitis as well.
Yes, sir.
Yeah, so the thing was this child had a proportionate short stature, which was not picked up on the pediatric follow-up. And because of the ocular fix which was seen, that triggered off the investigation in the form of MRI, and they were referred for that. And we confused initially whether it could be pituitary macroadenoma. And then our surgeon also said we'll probably require a surgical intervention. And then by that time, thankfully, the endocrinologist got involved on day one itself. And then we said we'll have to do all the evaluation first. And when the TSH was high, then we had this possibility of secondary hyperplasia and this extensive evaluation. Now, after the methylprednisolone injections, she's slightly better. She is walking and seizures are not there. And gradually getting better. But so we'll have to call back because just today we received the NMDA report. We just thought because there are so many autoimmune things going on, let us do all the autoimmune panel. So said the NMO MOG and NMDA as well as part of that, and then this comes strongly positive.
Can you please clarify my confusion? On one side, you insist on short stature and on constipation, and on the other side, you argue that this is an acute onset hypophysitis. So this is
No.
You argue this is not the congenital hypothyroidism, is it?
Yeah, this is not congenital. This is not congenital. The short stature, I think
the short
the age
stature is not explained by
last 1 year. Last 1 year, our bone age is at 3 years of age. She is 4 years. Her bone age is of 3 years, so probably this has onset around 3 years of age.
Or could be a constitutional delay.
Mid-parent, yeah, according to
Yes.
yeah, sorry, go, Harika, you can answer.
Sir, according to mid-parental height, like child is not coming under familial short stature.
And cognition, prior cognition, you have any information, was in normal limits?
Yes, sir. Prior cognition was normal. Since 15 days, child is having slow response.
Yeah,
and
but
previously child was normal. So like child had attained all the milestones according to age previously.
Thanks.
I had a question. Is it possible that the whole thing was because of endocrine kind of thing, because you had severe hypothyroidism, and maybe that caused, but this NMDR, is very odd because I mean, if it's the NMDR, obviously it is acute NMDR encephalitis, but then this thyroidism doesn't seem to make any sense unless there are two diseases in the same patient.
Yeah, the manifestations, she didn't have any other movement disorder. She didn't have psychosis, but she definitely had rigidity. She was unable to walk with some rigidity. So there are two components. One is seizures cognitive disturbances and this one. So if there was no hypothyroidism, everything we thought we could have explained by the NMDR. In retrospect now, because we just got it today. But all these things, I think she's somebody who is predisposed to significant autoimmunity, and multiple organs have been affected.
Yeah, just one point. By the way, I mean, there's a lot of debate whether there's anything like whether anti-thyroid antibodies are just, incidental or what do you call it, epiphenomena in these autoimmune disorders. And there's nothing really like a Hashimoto's or a steroid responsive thing. Have you read about this? Because recently there's a lot of discussion on whether it really exists.
Yeah, true. Now if the positive was that, but now it's into diam again. The positive NMDA.
Very interesting.
Harika, maybe you want to summarize, yeah.
Yes. So our take-home message from this. Our take-home message from this child presentation is thorough history and clinical examination are very helpful in reaching the diagnosis, as this child had history of constipation, sleep disturbances, and also proportional short stature, pointing to with hypothyroidism, and its analysis is important in any case. And this pituitary enlargement, like it can be due to end organ failure such as hypothyroidism, resulting in compensatory pituitary enlargement. With adenomas being very rare in children, so if a prepubescent female or young male child presenting with adenoma-looking pituitary gland, endocrine workup is mandatory.
Great. Thanks, Harika. Any other comments? I think that's because that's the last case. Dr. Mankad or again also as mentioned.
No, nothing more to say. I think, sorry, I got a bit distracted. I had a clinical case come up here in the last couple of cases where I was watching the screen. Once again, I have put my details there. Otherwise, people know how to reach me. I think we need to put an urgent communication out to one of the leading journals, and whoever wants to be a part of it. There has to be a bit of methodology in it to show that the particular aspect of the vaccine has been dropped off, and there has been a surge in terms of the manifestations, particularly on brain imaging. And it'll be useful to know how these children presented, if you are adding any cases, how they presented, what the workup was, and what was the outcome. But this will have to be done pretty swiftly if it has to be made public knowledge and something done about it. Going back to the mumps case, suspected mumps case. That's about it, really.
All right, thank you. Yeah, that was the last case. A short session compared to our previous sessions. We'll meet again on the 15th of March. Before that, I think we'll be meeting a few of you in person at the ISNR. So if you haven't registered and want to come, you're more than welcome to. Dr. Mankad is coming. It would be great to see him in person to Hyderabad, I think. I don't think it's the first time, but yeah. So we'll see you in a less than a week's time. Yeah. Thank you, everyone.
Otherwise, everyone can come to Goa instead.
Yeah, there's